a Puscast covering the first 2 weeks of December in the year 2020. References, as always, are available at edgydoc.com, the home of my multimedia empire. Otherwise, let's get straight to the literature, shall we? And as so often the case in the year 2020, let's start off with some COVID-45 information. As the COVID epidemic spirals out of control, it's always nice to know that it's actually worse than we think. This study looked at the prevalence of anti-COVID-45 antibodies in Chelsea, Massachusetts, which was the epicenter of COVID in that particular state. And they found a seroprevalence rate of 31.5%, half of whom had never been symptomatic. And this study was done April 2020, so I'm sure things are far worse off in Chelsea now than they were in April 2020. Another sidelight of this study is that IgM and IgG follow very closely on the heels of each other, rather than IgM first and then after a delay IgG, where IgG was found quite early, day 4, and started appearing only a day after IgM, similar with other serologic studies with COVID-45. COVID-45 binds to the ACE2 receptor to cause its particular panoply of symptoms, and there's been ongoing debate and studies about whether or not being on chronic ACE-ARB drugs is detrimental in patients who have COVID-45. And like so many studies in the medical literature, you can find them going either way. This study found that patients who are on chronic ACE-ARB and are admitted with severe COVID-45 have an increased risk of renal insufficiency. Whilst a study out of Sweden, in a population of 1.4 million patients that were evaluated, the use of ACE and ARBs was not associated with an increased hospitalization or mortality, although they did not look at effects on renal function in that study. So generally speaking, chronic ACE-ARBs does not appear to be detrimental in COVID-45 patients. I've mentioned before how Aspergillus seems to be an important complicating opportunistic infection in patients with COVID-45. This study compared having a positive COVID test on a BAL in patients with pneumococcus, influenza, or COVID-45 patients. And they found the rates of a positive galactomannan or other Aspergillus test to be about 10%, 10.9% in patients with COVID, but it was much more frequent in those with influenza, 22.9%. And they found the COVID-45 was only slightly higher rates of Aspergillus antigens compared to pneumococcal disease, around 6%, where it's considered to be a colonizer of the airway. So the take-home from this study is not only to worry about Aspergillus in patients with COVID-45, but also patients with influenza, where I've seen a couple of cases, all of whom have been marijuana smokers, for whatever that's worth. And an ICU in Brazil saw a big jump in candidemia in their COVID-45 patients, particularly those on a ventilator. And that doesn't surprise me. Lymphopenia, steroids, next thing you know, you're going to be candidemic. Although I have yet to see a candidemia patient in one of my ICUs. The big complicating infection has still been Aspergillus. Again, it's important at the time of admission to remember that patients with COVID-45 rarely have a concomitant bacterial or fungal infection, although they often get treated for CAP. In this particular study, they found only 8% of patients had a bacterial or fungal co-infection, yet 3/4 of them were placed on antimicrobial therapy. I spend a lot of my time in COVID patients stopping the ceftriaxone and azithromycin that comes up from the emergency room. One of the rules of medicine is seemingly once an antibiotic gets started, the only person who can discontinue it is the infectious disease doctor. I use the terribly fallible approach of a clinician. If they are producing lots of sputum and or have a densely consolidated lobar infiltrate on admission, I add antibacterial therapy to the patient with COVID-45. But as I say, most of the time, I'm stopping antibiotics. Some COVID epidemiology, this one from the Annals, quote, African American, Black, and Hispanic populations experience disproportionately higher rates of SARS-CoV-2 infection and COVID-19 related mortality, but similar rates of case fatality. Although I would say at my hospitals, the vast majority of morbidity and mortality has been in the Hispanic population. In China, women got more COVID, but they had milder and COVID and were less likely to die of it. So there's also some gender differences. And while having diabetes increases your chance of morbidity and mortality from COVID-45, being on metformin, yay, is protective for going on to develop ARDS, but only in females. Sigh. And since women tend to do better anyway, maybe it ain't the metformin. By the way, you may be hearing some occasional whining in the background or some snorting sounds. That's Winnie, my son's English bulldog. He sometimes wants attention. And I have discovered that bulldogs are fairly stubborn animals. A reminder that there is perhaps an association between COVID-45 and Guillain-Barré, and as I learned on a recent case, there are cases of transverse myelitis associated with the virus as well. And finally, as we head into the doldrums of the long, cold, dreary winter, remember that sunlight is good at killing off COVID-45, as is warmth. And while, quote, the incidence of diseases declines with increasing temperatures up to 52 degrees Fahrenheit and is lower at warmer versus cooler temperatures, the association between temperature and transmission is small, and transmission is likely to remain high at warmer temperatures. Hear that, Florida? I don't think so. I think that's enough COVID. Let's move on to other fatal respiratory viruses. How about respiratory syncytial virus? This is often a bad disease in the elderly. And one of the interesting things that has evolved over the last couple of years, now that we have molecular techniques, is how often viral infections come in with superimposed bacterial infections, or perhaps vice versa. I bet a virus first, and then you get a bacterial process. They found in patients who had RSV as a cause for their admission, they had a superimposed bacterial infection in 12%, about the same rate that you see with COVID-45 and less than perhaps the 30% you see with influenza. There are a variety of hantaviruses throughout the world, and there's one in Argentina, Andes virus, that causes a hantavirus pulmonary syndrome. There was an outbreak that was unique in hantaviruses, is that there was a lot of person-to-person spread at super spreader events caused by large numbers of people getting together. I guess it would be the MAGA events, Make Argentina Great Again. But it was interesting that this was a hantavirus that had super spreader events that led to the outbreak. As they note, quote, the super spreading capability of the Andes strain shows a facility for sustained continuous change of transmission if no control measures are enforced. More things change, more things stay the same. The HPV vaccination is effective in preventing rectal and oral HPV in men who have sex with men, which presumably will lead to less cancer in those areas as well. I still find it cool that we have a vaccination that will prevent cancer. This really should be a vaccine for anybody before they start to become sexually active. It's quite remarkable how well it works. A nice reminder that syphilis is booming in the United States, and besides men who have sex with men, this review points out that it is common in U.S. women who have HIV, who use injection drugs, and who are African American. But always remember that sex is often exchanged for drugs, and with it comes sexually transmitted diseases. Like MRSA infections, of which I've been seeing a lot more endocarditis in females, I've also been seeing a lot more syphilis in females, or at least diagnosing it. But I presume everybody has syphilis, especially when they have some sort of clinical presentation that I can't figure out. I think I initially said the hantavirus article is out of Chile and corrected myself to Argentina. It's an article on leptospirosis that came out of Chile. And what they found is that cats, feral cats, were an important potential reservoir for leptospirosis, with seropositivity rate up to 33%, depending upon the, quote, geographic area and cat's lifestyle. I didn't know cats had a lifestyle, but it's outdoor cats that tend to have leptospirosis. So while I tend to think of leptospirosis as cows, pigs, and dogs, probably need to add cats to the list, especially those with that specific lifestyle. That, I suppose, the rich and famous cats. So for bad C. difficile, it's not unusual for patients to be put on oral vancomycin and IV metronidazole. Does it help? Well, this was a retrospective study that looked at whether or not adding IV metronidazole was a benefit for non-fulminant or fulminant C. difficile diarrhea. And they had a little over 2,000 patients, 999 of which had combo therapy and 1,121 had monotherapy. And they found, drumroll please, dual therapy didn't do diarrheal stool. It didn't alter death, it didn't prevent recurrence, and it didn't prevent colectomy. But I suspect this study will have zero impact on practice whatsoever. It's hard to get people to break the idea that more is better. Although it is true of ice cream. Regular listeners, which as I said before is probably a DSM-4 diagnosis, know I have this affinity for vascular events as a complication of infections. Infections are inflammatory, inflammation is prothrombotic, and prothrombosis leads to a variety of vascular events. This study looked at acute cardiac events as a complication of pneumococcal community-acquired pneumonia and found that, yes, indeedy do, there's an association with pneumococcal pneumonia and subsequent arrhythmias, heart failure, and myocardial infarction, most of which occurred within 48 hours of admission. Who's at risk? Older people, pre-existing heart conditions, bacteremia, septic shock, high-risk pneumonia. So the sicker you are, the more likely you are to have a cardiac event with your pneumococcal pneumonia, but you should not be surprised when you see it in your patients. I guess this one should have been in the COVID section of the Puscast, not the bacterial section, but there's a report of an outbreak of carbapenem-resistant Acinetobacter baumannii in patients during the COVID-45 surge. Part of the risk for this was likely due to the fact that the hospitals were overwhelmed and undersupplied, and as such were using their ventilator circuits longer than usual and not doing the usual PPE because they needed to conserve it. Well, one of the many downsides of our horseshit response to COVID and the lack of appropriate PPE appears to have been an increase in carbapenem-resistant Acinetobacter infections. Yay! And a case report of 2 kids with melioidosis who got erythema nodosum, a hitherto unreported manifestation of melioidosis. And I keep being amazed at what a lousy job we do with what should be straightforward medicine. I mean, I can't believe how people treat cellulitis with vancomycin and Bactrim and all sorts of things that they don't need for what is a group A strep infection. And also, we still haven't figured out that you should not treat asymptomatic bacteriuria. And this study looked at patients presenting to an ER and subsequently being admitted. 74% of the patients with asymptomatic bacteriuria were started on antibiotics in the emergency room. And then once the antibiotics were started, 80% of them were continued on the antibiotics for at least 3 days. That's a ton of unneeded antibiotics. Did these antibiotics help the patient? Well, no. It was associated with a longer length of hospitalization and, of course, an increased risk of C. difficile, but did not improve outcomes. This was, by the way, an academic center, the University of Michigan. I remain amazed at how much crappy care gets delivered in university hospitals, and then they report it. I would be surprised if the community hospitals I practice in are any better. It's not unusual for me to stop antibiotics in patients with asymptomatic bacteria on whom I am consulted, but you'd think university hospitals would at least sort of be the leaders, the example setters. Well, often it seems to be the opposite. I have my biases, but if I should ever get a weird illness, I want to be treated in a community hospital, not the university of anything. Well, let's continue with How to Win Friends and Influence People by Mark Crislip. Weekly isoniazid and rifapentine has probably become the treatment of choice for latent tuberculosis. It's just once a week. It's only 12 weeks. Patients tend to tolerate it well. And this looked at reported adverse events from this combination. There were no deaths, but what was interesting was the predominant adverse reaction, and this is a passive system, so who knows how many adverse reactions have really occurred. But the big one was hypotension, which 9 patients had. The other big one was in 5 patients who had elevated serum aminotransferases, or as we like to call them in the biz, LFTs. But I did find it curious that hypotension was a potential adverse reaction to the combination. All of us know that necrotizing pancreatitis is a very difficult process to take care of, and there's always a lot of hand-wringing going on as to whether or not the phlegmon, which sounds like a Jamaican term, is infected or not. I'll spare you my Jamaican accent pronouncing the word phlegmon. I'm not good with voices. Though I've always thought for the newscast that the weather report should be done by someone with a Jamaican accent. The sports should be done by somebody with Scottish accents, maybe Irish. And the main newscasters should be Indian, New Delhi style, not Native American. They're just so much more pleasing accents to listen to than the usual Midwestern ones we get on the newscasts. But that's just my bias. But it would make the news a lot more pleasant to listen to. But anyway, back to phlegmons. This was a retrospective review of the literature that asked the question, how often do you find Candida in patients with necrotizing pancreatitis? And about a quarter of the time, you will find a fungal infection, which was associated with a variety of increased morbidities as well as mortality, although there's only one kind of mortality. But 1 in 4, that's a lot, and might skew my diagnostic and therapeutic interventions for fungi more towards the sooner rather than later end of the spectrum. An elevated C-reactive protein at the start of cryptococcal therapy is associated with increased mortality compared to those with lower C-reactive proteins, but who cares? What do you do differently? Nothing. So why order a C-reactive protein? That's why I think they should be called CRAP, C-reactive protein, rather than CRP. Another lab that predicts severity and mortality is CSF lactate levels. And if it is higher than 5, patients did worser. But again, what are you going to do differently? I'm just not a fan of wasting money on tests that don't alter therapy. And finally, there's more to Cryptococcus than Cryptococcus neoformans and Cryptococcus gattii. There are a variety of other cryptococci that cause disease, including Magnus and Laurenti, which I've seen twice as a cause of vaginitis, and Ater, A-T-E-R, not A-T-E-H-E-R. It's not named after a cannibal. Maybe it's pronounced otter. Who knows? But this study looked at whether or not other cryptococci were associated with disease, and the answer is most of the time not, and only once caused invasive disease. So while there are other cryptococci out there, they don't cause a lot of disease. A series of patients with leishmaniasis and diabetes found that patients with leishmania and diabetes have a poor outcome, But curiously, they also have different skin lesions. And in this series, what they had was, quote, atypical cutaneous lesions characterized by large superficial ulcers without defined borders. Sort of the opposite of physicians without borders, we have ulcers without borders. But patients with diabetes had unusual skin lesions and tended to respond poorly to antimony. Didn't report how they did with Uncle Moni. A pair of articles in JAMA suggest that the risk of AAA dissection due to quinolones is very small, and as such, you can probably give quinolones safely if you have to. Compared with other antibiotics, they did not find a risk of aortic aneurysm or aortic dissection. And we'll finish up with a poll of infectious disease doctors as to when they would transition patients from IV to oral therapy. And it's nice to know that I'm pretty much doing standard of care. For gram-negative rod infections and streptococcal infections, yes. For Staph aureus and endocarditis, no, for the most part. What surprised me is that a few ID docs would give either phosphomycin or nitrofurantoin for gram-negative bacteremia. I don't think so. But my take has always been, well, not always, but for the last decade or so, that bacteremia is fundamentally important. It's all about the source control, the big exception being Staph aureus and endocarditis, where you often don't have source control as a manifestation of the bacteremia, which is why you don't want to give oral therapy. And that ends this Puscast, a review of the infectious disease literature of sorts for the first 2 weeks of December in the year 2020. This will be the last Puscast of the year. I'll probably be doing the next one somewhere around January 2nd or 3rd. So get your COVID-45 vaccine. And as always, I wish all my listeners a generic, non-denominational seasonal greeting. See you in 2021. God, where'd the year go?